Okay, let's go ahead and get started. Good afternoon. Thanks for joining us for Medical Grand Rounds. I'm David Schwartz, Chair of Medicine. The presentation that's going to occur over the next hour will be recorded for future reference and will be available to the broader audience. You'll be muted when you enter into this meeting. But at the bottom of your screen, you'll see a Q&A icon. Use this icon rather than the chat feature to submit your questions. And at the end of the presentation, I'll moderate the questions with our presenters. Today's Grand Rounds takes the place of the department's annual Holocaust Remembrance Lecture, which is put together by the Center for Bioethics and Humanities and is held each year during the National Week of Remembrance of Victims of the Holocaust. The Center for Bioethics works with partners including Physicians for Human Rights and the U.S. Holocaust Memorial Museum on this unique program, which is largely funded by local donors and foundations, and we're very grateful to those donors and the foundations that have contributed to the center. Next Thursday at 2 p.m. on Yom HaShoah, the Day of Remembrance, the Center for Bioethics and Humanities will be hosting a webinar panel on crisis triage and people with disabilities, historical lessons for a time of COVID. You can see at the bottom of your screen, there's a website for you to sign up for this webinar, and please use that website. It'll appear at the end of the talks this afternoon as well. One of the many challenges that we're facing in modern medicine is advanced care planning and allocation of limited medical resources. The urgency of these medical ethical decisions have only been highlighted by the COVID crisis. Today, we have 4 excellent speakers to help us understand medical decision-making and medical ethics in the time of COVID. Jean Kutner will introduce issues in advanced care planning. Dan Matlock will discuss how COVID crisis changes conversations with patients about utilization of resources. Channing Tate will discuss how health disparities figure into decision-making. And Matt Wynia will present a recap of how disaster planners have thought about ethical triage, especially considering worst-case scenarios. So let's get started. Jean, I think you're up first.
Good afternoon, everybody, and thank you for joining. And I know that people have joined to be hearing about crisis standards of care and crisis triage. And there's a number of us, including some of those on this Grand Rounds today, that have been putting a lot of time and effort into thinking about these issues as we're all working on addressing the needs during this COVID pandemic. And as we've been doing that work, both locally across the state, and then there's a lot of work across the nation, it's really brought to light that even in a time when there isn't scarcity, so right now, state of Colorado, we have enough ventilators, if we use that as an example, we still need to be doing activities that meet the needs of our patient and are offering care that we think is going to benefit our patients. So I'm going to start with that framing of things that we can and should be doing all of the time as we provide healthcare, medical care, but especially now that we have populations that are at risk for some pretty significantly poor outcomes with COVID. The 2 things that we've been talking about along these lines most frequently are things having to do with advanced care planning and honoring patients' goals and wishes. And the way that we've been framing this is that we need to be making sure that we really understand and know what our patients' goals and wishes are. This again should be an all the time, but especially now. And this is what we put in that bucket of advanced care planning discussions and documentation. So very patient-centric, and I'll talk a little bit about that. And then the other bucket that we've been thinking about is the question of making evidence-based treatment recommendations to the best extent that we have evidence, and not offering interventions that we, from a medical perspective, determine to be non-beneficial. So I'll go into two of those in a little bit more detail. And this is not just something that we're thinking about. If you haven't seen this New York Times article, it was just published at the end of March. It really emphasizes why during this pandemic, this advanced care planning is so important. Our patients and the public are talking and thinking about these topics. And I might just read a small section from this article to really bring it to light for us. The author writes, "Our collective silence about death, suffering, and mortality places a tremendous burden on the people we love and on the doctors and nurses navigating these conversations. We should not be discussing our loved ones' wishes for the first time when they are in an ICU bed, voiceless and pinned in place by machines and tubes. Talking about death is ultimately talking about life, about who and what matters to us and how we can live well even when we are dying. Rather than being motivated by fear and anxiety, we can open these discussions from a place of care and concern." So when I'm talking about advanced care planning, this is what it's all about. It's about opening that conversation with our patients, with our own families, actually with ourselves, about what it is that we would want, what is important to us, should we become seriously ill. And we all well know that these discussions go much better when they occur prior to being hospitalized. And this has only become magnified as those of you that are on the front lines of caring for patients with COVID or caring for any patient in the hospital right now with visitor restrictions, to be having these conversations for the first time when somebody is seriously ill and you're not able to have those conversations in person or face to face. So when I'm talking about advanced care planning, I'm talking about medical durable powers of attorney. So the ability for me to say who I would want to make decisions for me in the future if I lose the capacity to do so. That is really the most important component of this, is to have somebody who can be that patient's voice, who actually knows what it is that that patient would want and value. There are other forms of advanced care planning that you may know about. Living wills, there's a Colorado CPR directive, there's most forms. But really the thing to emphasize is that, especially before people get sick, to be able to have an advanced care plan in place and really know what it is that somebody would want. And as Matt gets to more talking about crisis standards of care, the last thing we want to be doing is to be intubating or having on a ventilator somebody, or in an ICU, somebody who didn't want it in the first place, and then they spend their last hours and days in isolation, literally, in an ICU that they maybe didn't want in the first place. A few resources for people or that patients that are UC Health patients. This is a screenshot of actually my Health Connection account through UC Health. There is a section on advanced care planning within My Health Connection that includes a nice instructional video, some resources, and then patients and we all, as you see on the right side there, the ability to actually enter a medical durable power of attorney through My Health Connection, which is our patient portal, that then gets automatically uploaded and into the right section in the chart. So I encourage all of us that have this access, and to encourage your patients to take care of that. For those that aren't UC Health patients, there's some terrific other online resources. This is one, Prepare for Your Care, that was developed by Rebecca Sidori out of UCSF. It is very patient focused. It has great videos. It's a step-by-step kind of walking through what are the steps to be able to document your goals and wishes, and then it is an online form that patients can complete. So that is the kind of patient-focused piece of it. The other part that's come to light as we've been facing, taking care of patients with COVID is this question of non-beneficial interventions. And again, this is something that it's a medical decision. It's our decision as medical personnel, as physicians, whether to offer an intervention because it is potentially beneficial or not for a patient. This definition that you see up on the screen is the definition of non-beneficial intervention from our UC Health non-beneficial intervention policy. And it walks through what may be considered a non-beneficial intervention. And you see there the interventions that will only prolong the active dying process, has the potential to cause injury, pain, or suffering that's disproportionate to the expected benefit. Of course, this is again why advanced care planning is so important. If it violates the patient's expressed wishes or goals of care, or other scenarios that you can imagine where it's not expected to achieve its goals. And this is not just our policy. If you look at the AMA Code of Medical Ethics, section 5.5, and I'll have the reference for you. I'll just briefly read that for you. Physicians should only recommend and provide interventions that are medically appropriate, i.e. scientifically grounded, and that reflect the physician's considered medical judgment about the risks and likely benefits of available options in light of the patient's goals of care. Physicians are not required to offer or to provide interventions that in their best medical judgment cannot reasonably be expected to yield the intended clinical benefit or achieve agreed on goals of care. Respecting patient autonomy does not mean that patients should receive specific interventions simply because they or their surrogates request them. And again, this is information that precedes COVID, and I think it's not something that we necessarily always think about when we're providing medical care, but it becomes particularly salient during our current pandemic. We here at UC Health, for our emergency departments, have actually created this resuscitation appropriateness pathway that brings these concepts together. So the first question is attempted resuscitation, including ACLS or intubation, actually a non-beneficial intervention? And this is a medical decision. This is not a scarcity decision. This is a medical decision. And as you go down, as you're looking at the left side of it, then it goes through what the provider should do next if the decision is that it's a non-beneficial intervention, that there is always something we can do, which is to focus on the patient's comfort and support, and we link to those sort of resources. And then the right side is the other aspect that we were talking about. If it's potentially a beneficial intervention, before we just offer it or provide it, it's understanding what the patient's goals and wishes are. And this is why having that documentation, if a patient didn't want that intubation in the first place, having it documented is so key. And people may say, well, okay, why now? This has always been important. But I would refer people to this terrific viewpoint that was published at the end of March in JAMA by a group out of Seattle. So they've been at the time they published this, they have been taking care of COVID patients for a number of weeks, and it really points out the high rate of mortality for hospitalized patients with COVID, and particularly for the older adults, and especially for those who are over the age of 80 and those who have multiple comorbidities. So the real point is that if we do get to the point of scarcity that Matt's about to talk about, we want to make sure that we're actually allocating scarce resources to those who wanted them in the first place. And the only way we know that is if we've had those discussions before patients get ill. So just one key point from this article, and then I will actually go to my next slide, which has some resources, and then I'll pass off to Dan. So from the JAMA article, In the context of COVID, advanced care planning prior to serious acute illness and discussion about goals of care at the onset of serious acute illness should be high priority for 3 reasons. First, clinicians should always strive to avoid intensive life-sustaining treatments when unwanted by patients. Second, avoiding non-beneficial or unwanted high-intensity care becomes especially important in times of stress on healthcare capacity. And third, provision of non-beneficial or unwanted high-intensity care may put other patients, family members, and healthcare workers at higher risk of transmission of severe acute respiratory syndrome coronavirus 2. Now is the time to implement advanced care planning to ensure that patients do not receive care that they would not want if they became too severely ill to make their own decisions. I will now pass over to Dr. Matlock.
Thanks, Jean. Let me share my screen here. Does that look okay? All right. So yeah, thanks, Jean. I'm Dan Matlock. I'm an associate professor of medicine in the Department of Geriatrics. I lead the program for patient-centered decisions at Accords, and I'm going to talk about the changing ethical landscape in the setting of COVID, and a little bit, and also how we should think about talking to patients during this time when we're worried about things like scarcity. So I think one of the reasons people have probably tuned into this talk is to hear a little bit about, or especially hear Matt talk about these crisis standards of care, but these come out of this shifting ethical frame where we have sort of this long history of affirming this patient-centered ethic in this country. And this history comes out of a long history of Supreme Court cases beginning in the early 1900s with Mary Schlendorf. And here are a couple more recent cases that many might remember, some famous ones. One was Karen Ann Quinlan in 1976 in New Jersey, and she was in a comatose state on a ventilator and with artificial nutrition and hydration, and her parents, the Supreme Court ruled that her parents had the right to take her off of a ventilator. But artificial nutrition and hydration was continued for 9 more years. And then more recently, in the Nancy Cruzan case in Missouri, in 1990, the U.S. Supreme Court allowed them to stop artificial nutrition and hydration. And the quote from the Supreme Court is, "The administration of artificial nutrition and hydration without consent is an intrusion on personal liberty." And this is sort of the predominant ethic that we're used to practicing in this country right now, where this patient-centered care, patients have the right to choose, they have the right to say no to things, and as some of the things Jean just talked about with advanced directive is planted firmly in this ethical soil of autonomy and patient-centeredness. And then another law in 1990 further affirmed this, the Patient Self-Determination Act. And this was a law targeted at healthcare facilities, not necessarily individual clinicians. But it basically said that every patient admitted to a hospital has to be given some information on their rights and policies regarding advanced directives. Facilities must ask patients about advanced directives. Facilities must educate staff about advanced directives, and healthcare providers may not discriminate against patients based on advanced directives. Again, this is this soil of patient-centered care that we're used to. And patients want to talk about this. This is an old reference, but it's still a good one, where over 100 patients with severe lung disease, COPD, were asked preferences about things like intubation and if they wanted to talk to their physician. And you look and see 94% had some opinions about this, and 99% wanted to talk to their physician. Only 19% had actually talked to their physician, and only 14% actually believed their physician understood their wishes. And there's more recent data with similar results, but this one's a very clear example. Likewise, physicians often don't know when these things exist. This is some research that about 3 out of 4 doctors whose patients had advanced directives were not even aware that those documents exist. And this is this idea of we have to ask the patients their wishes, and this is this sort of modern ethic that we're comfortable practicing in this patient-centered care. But in a time of COVID, in a time where we're talking about scarcity, you have a shift where we go from this predominant focus on patient-centeredness to a need to focus on community ethics. This is that balance between autonomy and justice that it's one of the classic ethical conditions. And if we are in a state of scarcity, we have to change our ethical thinking. These next couple slides are thick slides, but they're great. I actually stole these from Matt Wynia, with his permission, of course. But it's a nice summary of ethical principles that guide things when we move this shifting ethics or ethical principles we should be focusing on. And I won't go through all of these, but just to highlight some of these, there's substantive principles and procedural principles. And some of the substantive principles are things like fairness, equity, and the fair allocation of resources. Other principles like duty, medical professionals should accept their professional duty to treat, even at the risk to themselves, which we are seeing many people doing right now. Leadership must recognize one of their roles is to be a steward while also making sure they make decisions with input from others and multiple stakeholders. Proportionality is a very important principle that Matt's going to talk about in his section. And then protection, the idea that as things get a little chaotic, we have to do our best to maintain social order. But I want to talk about these principles a little more closely. These are the procedural principles when we actually go and start practicing and move towards crisis standards of care. What kinds of things do we really need to be thinking about? And these are really important. First of all, inclusion. Channing Tate is going to talk next about disparities in COVID, which we're all really starting to see and is becoming more obvious to everybody. But the importance, if you do crisis standards of care, of being very inclusive of multiple stakeholders with multiple perspectives, that helps build trust in the process and helps us, when we get to the other side of this, maintain trust, which we're at risk of hurting if we don't do these things correctly. And transparency. Anytime you move towards crisis standards of care, the importance of being transparent in our decision making is really paramount. So this gets into a question. This is a paraphrase of a question that Matt Wynia asked us a few weeks ago. We were talking. Our group does research and shared decision making. We make decision tools and decision aids for patients. And he asked, how do we compassionately and respectfully ask people about decisions that are really tough, like whether they would willingly give up a chance at being on a ventilator if there were an absolute shortage? Is that something we even should be asking people? It's almost trying to bring a little bit of that patient autonomy and patient-centeredness into this time when we're focusing on the community ethics and scarcity. So our team, under his guidance, we had a team of people working on developing a tool, and we went through a rapid prototyping process in the development of a tool with about 40 different stakeholders, including patients, ICU physicians, hospitalists, communication experts, lawyers, and went through about 12 versions in 8 days with rapid prototypes to try and ask this question of, is there something we could hand patients to help explain this? Help explain that this is sort of a tough situation, and if we are getting into scarcity, what they would want. And we came to this question. It's a one-page document, and we came to this question after lots of iterations, but we ask, if you become sick enough to need a life support machine, what would you want? There's the typical questions. I want a life support machine if the machine is available, or the last option, I don't want one even if it is available. We added this middle one. I want one if it's available, but consider others who may be more likely to survive. I understand this would mean I am more likely to die. And this gets into this preference for altruism. And is that something we can even ask people? I asked, I have a smart psychologist colleague, Laura Scherer, and I asked her about any literature of the psychology of altruism. And she pointed me towards some of the research on the Titanic, where there was a large proportion of people that survived on the lifeboats that were women and children, and a very small proportion of young men, arguing that at times of chaos, people do make altruistic decisions for whatever those reasons are, whether it's a social norm or it's a deep held value. But this highlights one of the tensions that we've had. So we have put this document out. It is freely available. We didn't put any copyrights on this. We put a document version on our website here, so any other program can take this language, modify it for their settings in any way that is helpful to them and how they want to talk to patients. Developing something like this in 8 days is not ideal. You'd like to test this and really see how it works. But we're in a situation where we have to make decisions quickly. But that highlights some of the challenges as we switch to this ethic and how we talk to patients, like this tension in the development of the tool. We want to give people an opportunity to state their wishes and to state that altruistic preference, while also not wanting to coerce them or guilt them or put too much decisional weight on the patient. And that is a really tough tension to carry in this document. And we worked really hard to try and not do that, but it is an important tension to carry. Likewise, there is a tension in implementation that as the committee we've been meeting, a tension on when to use. Do we start it now and hand it to everybody in the hospital thinking we might have scarcity? Or do we wait until we're in a time of scarcity? And when to start using language like this? And then when should it be given should it be given in the ED or at the time of admission? And obviously there will be some patients who have a lot of questions about this, and who has the time to have that discussion? Is it a doctor? Is it a social worker? Is it a nurse? And these are some of the questions we've had. And, in a lot of the work we do, implementation is the hard piece of all of this. And we're having those kinds of challenges here too. So with that, I'm excited actually that you get to hear from Channing Tate next. She's the program manager for our team and has taught me a ton about disparities in this work. So with that, I will stop share and turn it over to her.
Sure. So good afternoon. As Dan mentioned, I'm Channing Tate, and I am a PhD candidate in the Health and Behavioral Sciences program downtown, hoping to finish up my dissertation research this fall. And I also am the program director for the Colorado Program for Patient-Centered Decisions. A lot of my research is focused on shared decision-making and health disparities. So I'm going to talk to you a little bit today about some disparities that we're seeing with COVID. So this slide is kind of busy, but I really just want people to focus on these two columns over here. What we know about people of color is that they have differential exposures to things. So overcrowded housing, no access to clean water. We all remember what happened in Flint, Michigan a few years ago. And they don't have the ability to stay home from work because they often have frontline jobs where they don't get paid if they don't stay home. And that also leads to some differential susceptibility and differential disease severity, with things feeding into that like psychosocial stresses, food insecurity, and access to healthcare. And then we know that people of color often suffer differential consequences and disease after disease has developed, with lack of access to care. And what we know is that ultimately this leads to unequal levels of illness and death in people of color. And if I were to boil this slide down to one sentence, I'm going to share with you an adage that we have in the African American community that is quite common. And it says that when white folks get a cold, we get a pneumonia. So looking at some of the race disparities in COVID as they stand today, so this slide just kind of highlights some of the disparities. You'll see on this graph where it has a lot of communities that have high percentages of African-American residents living there. And what this slide shows is the percent population of a given area and the number of deaths. So just visually, you can look at this and see that there are some pretty striking disparities. For example, in Louisiana, 70% of the deaths of COVID have been African Americans, but only 33%, African Americans only make up 33% of the population of Louisiana. And just this week, the CDPHE has released some race and ethnic data for the state of Colorado. And so what they say is that Latinx represents about 28% of the population in Colorado, and they account for about 22% of new COVID cases and 27% of all deaths. African Americans represent 4% of the population of Colorado, 7% of new COVID cases, and 7% of deaths. And then they're seeing some disparities with the Hawaiian and Pacific Islander community too. So Hawaiian and Pacific Islanders represent about 1.1% of the population of Colorado, and they're accounting for about 0.6% of new COVID cases and 1.6% of deaths. So I mentioned before that people of color often have jobs where they're unable to stay home at work, which increases their exposure because they aren't able to social distance. So we know that people of color and low-income folks are overrepresented in jobs like environmental services, custodial work, home health aides, nurse aides, grocery store clerks, shipping clerks for like Amazon and places like that, as well as emergency dispatchers for 911 and public transportation employees. So they have jobs that they're not able to telecommute. And this slide kind of highlights an example of this that's happening in our state right now. This is a photo of the meatpacking plant up in Greeley. And I don't know if you can see it very well, but this blob right here is a bunch of cows that are getting ready to be slaughtered. So you may or may not know that in addition to our meatpacking plant being closed, there are 2 other major plants across the US that have been closed in Sioux Falls, South Dakota, and Columbus Junction, Iowa, for COVID pandemics affecting those plants, and those plants are going to be closed indefinitely. And I kind of like this quote from Kim Cordova, who is the president of the United Food and Commercial Workers Union. Local 7 is the union that services Greeley. And she said that there may be significantly more individuals at the plant who are carrying the virus, but may either be asymptomatic, not tested, or afraid to come forward as they're not eligible for sick pay. So what we know about what's happening in Greeley now is that there are 3 unconfirmed deaths from COVID and at least 50 people who are tested positive for COVID. And if you've been following the news, you can see that there's a lot of bad press about the lack of transparency that is being shown with how that plant is handling this outbreak. So now I'm going to talk a little bit about some historical context that illustrate mistrust in healthcare. And the biggest one for me is the Tuskegee syphilis experiment, where in Tuskegee, Alabama, 600 African-American men thought they were getting free healthcare, but in reality, the United States Public Health Service, who sponsored the study, was just watching how syphilis ravaged the human body. And my colleagues are probably sick of me saying this, but it cannot be overstated how important this singular event is to African Americans in this country. As a researcher, when I go out into community, and I do primarily survey research, so it's minimal risk, people always say to me, Chan, you're not going to get Tuskegee on me, are you? There's a tremendous amount of fear and mistrust because of Tuskegee. So just keep in mind that the older people that you're interacting with in your clinics live through this, and it greatly affects how they interact with healthcare and their level of mistrust. Another historical incident is what happened with Henrietta Lacks. She was a tobacco farmer in Maryland and developed cervical cancer. Got treatment at Johns Hopkins, and during her treatment, the researchers and doctors harvested some of her cervical cancer cells, which became HeLa cells, which are the basis for the polio vaccine and for the HPV vaccine. The problem with this is that she didn't know that they took her cells, her family didn't know that she took her cells, they didn't ask her permission or her consent, and nobody knew about this for several years. This became very highly publicized a few years ago with the book, The Mortal Life of Henrietta Lacks. And again, it was like another slap in the face for African Americans about the lack of transparency and the amount of mistrust in healthcare. My last example is not necessarily a healthcare crisis, but Katrina was a very big public health crisis that really reignited this feeling of people of color in this country that were disposable. And part of that was because of the country's response to Katrina. And I can see parallels between that and what's happening with COVID, with the lack of transparency about race and ethnic disparities in COVID, the absence of testing, the absence of care and things like that. So this photo is of a young man who's covering up his mouth to avoid the stench of 2 dead bodies that are just laying outside in front of the convention center in New Orleans. So if you've been watching the news, you can see that this is already starting to happen again with COVID. So this picture was on the news just this week, and it shows a hospital in Detroit, Michigan, where they're just sticking dead bodies in places because people are dying at such high rates from COVID. So to kind of throw some numbers on this, there's a big body of literature that studies mistrust in healthcare and people of color. And it looks at things like mistrust in diabetes management, mistrust in getting preventative health screenings, but it also looks like care settings. So mistrust in primary care, mistrust in specialty care, mistrust in accessing emergency services. But if you look at African Americans as a whole, 45% of African Americans report that they mistrust their healthcare provider versus 34% of whites. There's some new literature that's coming out that shows that some of this mistrust in healthcare is explained by prior experiences of racism, like Tuskegee, Jim Crow, Katrina. And for my dissertation, I enrolled 144 African Americans in the Denver area over the age of 65, and I'm seeing how they have high levels of mistrust too, citing some of these things as well. So overall, if you look at the country as a whole, only 31% of Americans trust public health officials to be transparent and honest in a time of a pandemic crisis. So that data came from a study that was in the New England Journal of Medicine. And that study also showed that just in general, Americans are in general losing trust in healthcare providers. So they cite a statistic that said that 73% of Americans trusted healthcare providers in 1966, but as of 2012, that number was down to only 34% of Americans. So I think all of this, the history of mistrust and what we're seeing emerge with the COVID crisis is kind of leading to this perfect storm where COVID might greatly exacerbate levels of mistrust that will be hard to overcome, much like Katrina. So this slide kind of shows some of the variables I think that are going to influence that mistrust. One thing that's not on here is socioeconomic status, but that definitely is an important variable here. And, the doctors on the panel will talk about resource scarcity and the stress that you all are under, but if we don't pause and think about it, I think we are at a point where mistrust could be really, really damaging. So what can we do? Obviously, COVID did not cause structural racism in this country, and obviously we can't fix structural racism and inequity right now. That will be my life's work, quite honestly, but we can build trust. And if you read the literature around trust building, most of it boils down to communication. So I think communication with your patients is key. Show compassion, show empathy, and acknowledge how hard it is for your loved one to be in an ICU and you can't be there by their side. Practice active listening. Spend the appropriate amount of time with patients and their family and be transparent. There's a huge body of literature that shows that people of color have higher trust and satisfaction in their healthcare providers when they feel like their healthcare providers are being transparent with them. And I'm not a doctor, and I appreciate all of the hard work that all of the doctors are doing right now. And I'm not advocating that you all spend 30 minutes sitting in a room with your patient, but I have been a loved one of someone who was terminally ill in a time of crisis. And I can tell you with my father, who lived through Jim Crow and Tuskegee and had high levels of mistrust, it really, really impacted how he felt about his doctors, the people who walked into the room and just said, "Hello, Mr. Tate, who's this with you? Your daughter, tell me about your daughter," and just spent 3 or 5 minutes trying to connect with the patient on a human level. So with that, I am going to turn it over to Dr. Wynia.
Thank you. I realize I have like 6 minutes, so I am going to go really quickly through a number of slides here on why we are talking today about crisis standards of care. And I'm going to start in 2009, although of course many of you know that there were a number of important reports and work products around altered standards of care and so on relating to the SARS epidemic, relating to the flu vaccine shortage in 2004, relating to Hurricane Katrina. But this, in 2009, for those of you who were practicing then, you may recall that we had a flurry of cases early in the year, in the spring, and then the flu went away for the summer. And there was a very strong concern because this was a pandemic flu, zero pre-existing immunity to this, that we would be slammed when the fall came along and that we could have many, many millions of cases. And so in the summer of 2009, the Institute of Medicine pulled together a committee to look at crisis standards of care in the anticipation that we would have moments in the flu pandemic to come where we would have many more people who need ICU level resources, including ventilators, than we would actually have. And I'm going to just sort of go through these slides and make 1 point per slide in view of the short time. So point number one, one of the things that the Crisis Standards of Care report from 2009 really emphasized is that crisis standards of care is not a choice. This isn't something you decide to start using crisis standards of care. Crisis standards of care are made necessary by the circumstance in which you live. These are forced choice, triage type decisions. And while it would be nice to have legal protections, and it would be nice to have organizational guidance on how to make these kinds of decisions, the reality is if you have to make these kinds of decisions, you actually have to make these kinds of decisions. There's no, I think I'll wait and decide later which of these patients, get the last ventilator. So these are not optional. A crisis standard of care arises and sort of takes over the circumstance. The other thing that was recognized right off the bat is that this is difficult to find the right language here. So we talk about crisis standards of care, but in fact, the standard of care is the same in a crisis circumstance and a normal circumstance, because the standard of care depends on the circumstance. So your obligation legally and ethically always is to do the best you can given the current circumstances. And obviously a disaster is not your normal routine. So the best you can do is different under those circumstances than under normal circumstances. And again, this gets to the reality that it can become impossible to attain usual levels of quality in operations because of resource shortages. The Joint Commission says the aim when that happens is not to maintain the exact same quality of care, because that's not possible. The aim is to gracefully degrade the quality of care you're able to provide. Since 2009, and I love this slide because I took it from Dan Hanfling. I helped to plan a committee meeting on this for the National Academies back in November, where the point of this was we're 10 years after the IOM Crisis Standards of Care report. What have we learned? And Dan put up this slide saying these are sort of the major disasters since 2009, with a big set of question marks at the end, essentially to say, obviously there will be another disaster. We don't know if it'll be a hurricane or a pandemic or what, but there will be something. And of course, little more than a week later, the first case of COVID-19 was diagnosed in China. This is why we're worried about this right now. And I'm not going to belabor this, but these are sort of rough estimates of the potential morbidity and mortality for COVID-19. And it runs somewhere between seasonal flu and Spanish flu in terms of the fatality rate, and somewhere between the common cold and polio, or maybe even smallpox, in terms of how contagious it is. And I'll just, to give you some perspective, say that if we did not do the things we're doing right now, which we largely did not do in 2009 when pandemic flu came along, because, by the way, look at the 2009 flu at the bottom left. It turned out the pan flu of 2009 was about as deadly as the common cold. So only about 12,000 people in the US died from the pandemic flu in 2009. That's why many people don't even remember it happened. But do you know how many people caught the pandemic flu in 2009? 60 million Americans. Imagine if 60 million Americans caught COVID-19. Even at the very lowest mortality estimates, we would be looking at somewhere around 600,000 deaths. So we're doing a terrific job right now at reducing the spread of this, but it is still a very dangerous disease. And the estimates from, the Bob Trug piece here from the New England Journal a couple weeks ago said that if we did nothing, as many as 30 people might need ventilators for every one ventilator in the United States. So a month ago, we were terrified that we were absent social distancing measures, which appear now to be doing a quite good job of reducing the R naught, but absent that, we were going to be swamped, far worse actually than what has been seen even in Italy. This is the point to be made on this slide is that, and these are the data from England so far as of early this week. if you get COVID-19 and you need to be ventilated, that is a terrible disease. And I put this up because I want people to realize, although we talk a lot about triage of ventilators and access to ventilators, sometimes the implication seems to be that if you get a ventilator, you're going to survive, and if you don't get a ventilator, you're going to die. The reality, sadly, is that even people who get the ventilators rarely do very well. And in particular, if you get so sick that you need a ventilator within 24 hours of admission, the mortality rates are running in the 70, 80% range. And there are a number of studies from China where more than 85 or 90% of people placed on ventilators still didn't survive. Dan mentioned the change that takes place in sort of how we do ethical thinking during major catastrophic disasters, from looking at sort of the pure, I just care about the one patient sitting in front of me, to I need to look at the whole community. And I just want to put this up to say it's more complicated, unfortunately, than even that. Yes, we want to try and save the most lives. We want to do the greatest good for the greatest number, but we in fact do not shift to 100% utilitarian thinking during disasters. We're still worried about maintaining a good society, a society in which we all want to return. And this in fact is reflected in both our own at the University Colorado health system, as well as the state guidance. This is the aim of our triage guidance system. It's not just to save the most lives, it's to do so in ways that will sustain social cohesion, retain or improve trust in our healthcare system, and maintain our ability as a community to come together and heal in the wake of this disaster. Because this catastrophic disaster won't last forever. We will need to be able to come together. And if we do triage in ways that destroy social trust, that will have long-term repercussions, and we all recognize that. The duty to plan is about not needing to use crisis standards of care. The idea here is that we have a responsibility to try and avoid ever needing to use the triage guidance that we are putting into place. And I'm going to skip this slide and go instead to just say the risks of improvising as you go along are that cognitive stress, we all know, reduces our problem-solving ability, leaves people engaged in problematic behaviors like task lock or panic or paralysis. That if we haven't thought this through in advance, there are delays in using mutual aid and mobilizing resources. And in fact, there have been several lawsuits now to healthcare organizations for failing to plan for recognized hazards. Most of these around hurricanes, but I don't see any reason why a lawsuit couldn't also arise if a health system were to fail to plan for a worst case scenario right now, given what we know. This, again, is too much for me to cover in the amount of time we have remaining, but I just want to make the point that we often talk of triggers, but in fact, all of the planning that we're doing happens throughout an enormous gray space. So staff, supplies, stuff, all of these things are in flux at all times. And I put this up largely because of this principle of proportionality, which Dan mentioned. The principle of proportionality is not one that we talk about a lot in biomedical ethics, but it comes up a lot in public health ethics. This is the idea of doing that which will harm the least to achieve the desired benefit. And the importance of proportionality is that if you're going to do triage, the people doing triage need to not only do repeated assessments, because things are in flux and new resources may come in, or the person may start to improve and become a better candidate, but also you need excellent situational awareness. God forbid anyone ever take someone off a ventilator to give it to someone else at hospital A, and at hospital B, 6 blocks away, there was a ventilator available. So the people doing triage must have excellent situational awareness. I put this up because Hurricane Katrina is another example of this, where in the early phase of the response, the DMAT team in the Coliseum there actually black tagged a very large number of people as being expectant, meaning they were expected to die and should receive comfort care only. But as new resources came in, they would unblack tag people because they had resources or they had the ability to ship them off to somewhere else. And in fact, very few of the black tagged people ended up dying because of the situational shifting, resources and so on. These are the broad outlines of the Crisis Standards of Care Triage framework for the state of Colorado. And these are matched up very nicely to what we're planning for the University of Colorado Health System, where we really emphasize tier 1, which is looking at what is the likelihood that this person, given physiologic measures of illness, is likely to benefit from limited critical care resources that may be available. And if you have two people who are literally tied, who are statistically insignificantly different in terms of their likelihood of benefit, then you move, and only then would you move to a tier 2 consideration of, are any of these people children? Are any of these people first responders, healthcare workers who are working on the front lines? And those people would then, in a tiebreaker situation, those people would then be given the preference. If there is not a tie there, or if there is a tie in that tier, then you would move to tier 3, where we would look at things like pregnancy, single caregiver, years of life saved. And if all of these above are tied, then literally a random number generator would be used to decide who gets access to the scarce resource. This is similar to many other states and systems around the country. And I'm realizing that I'm pretty much out of time, so I'm going to do this fast. People often talk about triage as though this is how it happens, that you've got 4 people and you've only got 2 ventilators. That's not actually operationally what happens. Operationally, what happens is you may or may not have a triage score where you know that you're in shortage, and then someone comes along and they seem like they qualify, so they get the ventilator. Then someone else comes along and maybe they don't really qualify, so they don't get a ventilator. And then a third person comes along and maybe they seem like they do qualify. And then a fourth person comes along, and what are you going to do? Because now you're out of ventilators. So the triage operations have been incredibly difficult for us as a team and for our state to develop guidance around. So I'm just going to make 4 quick points here, and then we'll go to question and answer. Number 1, these are decisions that cannot be made by the bedside team because of situational awareness demands and because bedside teams have ethical and legal obligations. Also, triage teams allow us to avoid giving those triage teams unintentionally biasing information. So for example, you can give to the triage team a package of information about the patient that does not include the patient's race, that does not include disabilities that are irrelevant to survival. Number 2, scoring system issues we've had to deal with. SOFA score, the sequential organ failure assessment, is the one that almost everyone nationwide is using, but it's also true that everyone nationwide understands that SOFA is imperfect. It did not perform particularly well in the 2009 pandemic flu. There are pieces of the SOFA score that are virtually impossible to figure out how to use in a ventilated patient who's sedated, like the Glasgow Coma Scale. And there are aspects of the score that just are not adequate for contemporary ways in which we manage patients with COVID, using, for example, early norepinephrine to support blood pressure and so on. And yet, SOFA is probably better than nothing. We've got a number of other ways that we can think about scoring patients for their likelihood of survival. But the bottom line is we really need a score with better predictive accuracy. And fortunately, we have a very large team of people in our informatics and EPIC team looking at how to create a score that will perform better than the SOFA score. And that's what we intend to use should we ever need to use this. Third, people with disabilities, minorities, the elderly. I think we cannot ignore, as Channing mentioned, the fact that a perfectly accurate predictive score might end up disproportionately affecting some patients because those patients, because of underlying comorbidities, have higher likelihood of death. And we need to be tracking this. We need to be very clear about what our values are. I love Channing's list of the things that we can do right now. And I would just add on top of that, making clear statements of what our values are. Things like making it clear in our policy that we are not going to be admitting patients to our hospital and taking them off the chronic vent that they've been on for 20 years in order to give it to someone else on some kind of utilitarian calculus. And making sure that people understand we do not use categorical exclusions based on age or disease. And finally, the issue of reallocation and what comprises a fair therapeutic trial. So there's a lot of talk about if someone is doing poorly on a ventilator, when, if ever, might it be okay to remove that patient from the ventilator in order to give it to someone else who might have a better likelihood of benefit, better chance of survival. There's a lot of concerns about that, and we've spent a lot of time in our operational guidance trying to make sure that we have a duration of therapeutic trial that is adequate for the disease that the patient has, which for people with COVID-19 may be quite a while, because we would not want to have people on a trial event for 3 days. They're not doing well. You give it to someone else for 3 days. They don't do well. You give it to someone else for 3 days. They don't do well. And you end up with 3 people who all died when you might have been able to save at least one of them had you just given them a fair therapeutic trial. So let me end there and thank you all very much for your attention. And I look forward to the question and answers.
Thanks very much, Matt. Thank you, Dan, Channing, and Jean. This was a great series of talks and presentations and stimulated a number of questions. So let me start with a general question that I'm sure all of you have thought about. The question is, what lessons have we learned from living through this crisis as it relates to advanced planning, conversations with patients, health disparities, and disaster planning? How can we create a better healthcare system?
So I'll start because I think this is a question we get not enough, actually. I'm really glad that someone raised that right off the bat. One of the things that is recognized by people who do disaster relief work and disaster response planning is that there's sort of a canard that in disasters, the community fabric is torn and people become, you know, all for one and all for themselves. And the reality is that in disasters, communities actually tend to come together. And collaboration and cooperation is more common than in non-disaster response scenarios. So I'll give you one example. The state of Colorado has a system where everyone's supposed to put in what their resources are in terms of ICU level care. And this pre-existed this disaster, and it had about 40% of the data elements filled a couple months ago. Today, and by the way, there's a bunch of reasons for that. There are health systems that don't want to share information with each other. And there's, you know, perfectly good sort of market competitive reasons why people might not want to share all this information all the time. But that data set has better than 95% fill rate today. And you have health systems that are normally competitive with each other, cooperating in ways that are really unprecedented. And I think that is what we are likely to see during the catastrophe. And the question is, how do we retain that sense of a shared community? How do we retain that sense of collegiality? How do we retain the sense that, you know, Channing brought up of needing to have a health system and a decisional process that is worthy of the trust of our minority communities and worthy of the trust of people with disabilities? These are things that should not only arise during disasters, but disasters throw a spotlight on them and really give us a chance to figure out how to do things better. And I don't know how things are going to change in our healthcare system as a result of this, but you know, this is certainly a set of events that is, I think you have to go back to World War II to find a socio-ecological phenomenon like this in terms of its likely impact on our communities and the world. So we will see enormous changes as a result of this. And it's our obligation is to make those changes in the right direction.
Other opinions? Jean, it looks like you have something to say.
Yeah, I think maybe for the first part of that around advanced care planning, I think you know, we've always sort of thought and talked about that this is important. But I think given the increased attention on this and the real desire to be able to provide care that is really consistent with patients' goals and values, again, independent from scarcity, So I'm keeping a running list, as of a number of us, of things that have changed because of a result of this crisis that we want to keep going afterward. And the structures and the focus on advanced care planning is definitely one of those, David. We've seen across our entire ambulatory a focus on getting advanced care planning done before people get ill, putting in place the resources and the counseling and all to be able to do that, being able to do them through video visits, getting that awareness in the community. So I think that's one thing that has changed that I hope continues.
Channing, you had a number of suggestions for the future and for better communication and for improving trust. Do you have any other thoughts?
Yeah, so I really like what Matt said about how we are at a point in time in history where we can really change the paradigm and really change the conversation and be much more inclusive. And I loved what he said, like, I focus a lot on race and ethnic disparities, but Matt is absolutely right that we need to bring differently abled people and people with a variety of other disparities into these conversations about how we turn the corner after COVID and make a more inclusive, better system that benefits everyone equally. Dan knows that I say that it is my life's work to level the playing field for people with disparities.
Can I just say, by the way, we're talking quite a lot these days with the Colorado Hospital Association about rural disparities as well.
Right.
And I just want to put that on the table as one of the areas where I think some of the advances that are being made right now in terms of telemedicine are going to improve the quality of care that we can provide to rural communities. And it's amazing the barriers that had prevented telemedicine from taking off that just fell away in the context of a catastrophic disaster, because they were not really barriers, right? They were administrative, they were legal, they were socially constructed barriers that in a catastrophe people figure out how to fix those right away.
Let me ask a question that's more directed toward Dan, but again, I'm sure others have opinions. In aligning these decisions with what's happening at the bedside, there are physicians that are caring, or providers that are caring for patients that have quite a bit of information about that patient, that disease, that intervention, that are sometimes not accessible to the individuals that are wondering about how to communicate more effectively and also access to advanced planning. Give us some recommendations and a roadmap for how we can align those worlds.
Well, if I understand correctly,
Align the worlds of medical decision-making with medical ethics.
Oh, yeah, that's a great question. I mean, I think it is interesting, when I write grants on this topic, I say that patient-centered care sits very soundly on legal, ethical, and moral theories, but it doesn't actually sit very soundly on behavioral theories. And so a lot of these things around focusing on autonomy aren't necessarily how patients always want to behave, and they'll say things like, "Doc, I just want you to decide," or "Won't you give me a recommendation?" And if I understand correctly, I think one way to bring sort of the clinical part with the ethics together is, a question I commonly get is, can I make a recommendation and still be doing patient-centered care? And I would say, of course you can. I actually think shared decision-making is kind of half and half. You have a patient and a family who's an expert in themselves, and then a clinician who's an expert in the medical piece, and bringing those together is sharing a decision. So it gets into, how do you make a recommendation to somebody? You could say, well, based on the clinical situation, you should have this. And that could be very caring. But it may not be patient-centered. Or you could say, based on the clinical situation and based on the fact that you've told me that X, Y, and Z are what's important to you, I would recommend this. What do you think? And so you're bringing in the medical piece while also still respecting them and their values and wishes. And I think that's, if I understand the question correctly, I think that's one way to bring the ethical piece and the clinical piece together, is just acknowledge that they're both exceptionally important. And that everybody in the room is an expert. Someone's an expert in clinical medicine and someone's an expert in their lives and what's important to them. And that's one way. I don't know if that completely answers your question, but that's.
Jean's going to take another crack at it. You deal with this in terms of palliative care all the time, in terms of aligning decisions around end-of-life decisions and allocation of care with the physicians at the bedside.
Yeah, and I think, and again, this is aside from the scarcity of this discussion, this is all about, if I'm understanding your question correctly, David, about providing care that is consistent with the patient's goals and values. And if I look at it from how we approach it from palliative care, it's bringing together that's expertise. So we never walk into a patient room or have the discussion without understanding from the primary treating team, what are those potential treatment options? What are their potential benefits, risks, and burdens? And then bringing in from the patient's side of the story, what is important to them. And a lot of what we do is then help to match up the treatment that's being offered with the patient's goals and values. So for example, if the patient's primary goal is to spend as much time as possible outside of the hospital, but a treatment that's being considered would require them to spend much of their last weeks or months in the hospital, then that would be bringing together then, okay, if the patient decides that they'd rather spend that time out of the hospital, then from their bedside team, their primary treating team, what would that mean for them in terms of their life expectancy, their quality of life, et cetera. So it's really matching both of those levels of expertise. Is that what you were asking about, David?
It is. And where do we draw the line in determining medically non-beneficial intervention, especially in a disease we've never seen before?
Right. Well, and I think that this is probably why we struggle so much, honestly, as healthcare providers with this question of what is truly non-beneficial, and it is a medical decision. And I think especially in a brand new disease like this, it has to be, an ongoing evaluation as we get more data. I mean, if you look at the outcome data right now, both worldwide as well as locally, if you look at the overall, the outcomes of people who have COVID-19 who are over the age of 80 who get intubated, the survival survival to discharge is incredibly dismal. Probably the closest to 100% I've seen in something in medicine. But that may change over time as treatments change. So I think it's incumbent on us as healthcare professionals to understand that data such as it exists for whatever that decision is that we are making. And this is also why, as I've talked to providers, I'll get calls of can I not offer something. It's often helpful to have so a colleague look at the situation as well and get that feedback as well.
Good, thank you. Channing, I thought one of your initial slides that showed the multidimensional nature of health disparities was very helpful.
Mm-hmm.
We have a question from one of the participants, one of the audience. How do you distinguish between comorbidities and racial disparities? And is it even a relevant question to begin to think about those differences in terms of health outcomes?
I'm not sure that I totally understand that question.
The question really is the comorbidities, other diseases that individuals from underrepresented minorities might be at more risk of or not treated as effectively in, given access to health care, may contribute to adverse outcomes, in addition to the background of those individuals. And the question is, how do you distinguish between that? Should you distinguish between that? Is it all part of one package, as you presented in one of the earlier slides?
Okay, that's a great question. And I would love for the physicians on the panel to respond too, but I don't think you can distinguish between them, because when you distinguish between them, you set up this race-based paradigm of care. And I think this was highlighted most recently in the news when the Surgeon General of the United States went on camera and said, stop smoking, stop drinking if you're Black or brown. And so he was basically blaming Black and brown people for the disparities that they experience, when it's not just Black and brown people that drink and use drugs. So we need to stop thinking, we need to think more inclusively about care. And we know that because of some of these structural racism events, that people who are low income and people who are Black and brown do experience these diseases more and more severe and more aggressive forms of these diseases.
I just went backwards to the slide that I had on this because, which I don't know if the slides are still presenting,
Yep.
but this is sort of a core question, actually, to how you develop a scoring system that is accurate and also fair, because the reality is there are higher frequencies and higher severities of a variety of comorbidities that lead to higher risk of death among minorities, and the frequency and severity of those comorbidities has been determined by historic, economic, education, housing, work-related stressors, so all kinds of societal stressors. And so this is actually a paradigm example of what you would call a structural disparity, that these things are baked in. And as a consequence, whatever system we do, even if we think it's purely physiologic, it's only measuring the physiologic predictors of short-term mortality, it is still going to adversely impact people of color and people with disabilities, and right? Because there actually is a higher risk of death for those populations because of the higher rates of these underlying illnesses. But the higher rates of these underlying illnesses are not a result of, biology.
Yep.
These illnesses are not predetermined as a result of Black people having different genetics. They're predetermined as a result of Black people having fewer opportunities, fewer jobs, right? Growing up in different places, having more exposures. All of those are socially determined, not biologically determined. But then when we get to the scoring system, we say we're only looking at biology, we're not looking at social factors. But we are. There's no way to differentiate. There's no way to completely separate those, which is, I think Channing very nicely said, we are not going to fix all of the structural disparities baked into our healthcare system during a pandemic. But boy, does it shine a spotlight on them. And it does give us the opportunity to think about, what are the steps towards fixing them, and how can we build some of those steps in to our process so that it at least does not exacerbate the underlying disparities that are baked into the system.
We don't want to make things worse.
Yeah.
Excellent. It is multifactorial, and I thought that, Channing, your slide, one of your initial slides that showed that health disparities are a function of multifactorial.
Yeah, that's Sandra Krauss-Quinn's paper from 2014, I think, about why is it, if we have a pandemic, you can expect minorities to do poorly. So this was not, new knowledge as a result of COVID. This is something people have, in the pandemic preparedness community, have been thinking and writing about for a long time. We know that when epidemics sweep through communities, that I think Channing said it very nicely. When white people get a cold, Black people get the flu or pneumonia.
Pneumonia.
Yeah.
Yeah, I mean, this relates to another question that was brought up that I'm not sure we need to comment on, but I think it was an excellent point made by one person in the audience, that even having access to testing, sometimes if it's mobile testing that you have access to, then someone with a car can just drive up to a mobile testing site, whereas someone who doesn't have a car has to take public transportation to that testing site and potentially get exposed on the way or expose others on the way to being tested. Let me ask a very specific question about research practice and how it affects underrepresented minorities. Do standard research practices such as enrollment, exclusion criteria, trial design adversely affect minority communities in different ways? And how can that be addressed?
Yes.
Yes.
Okay, so how do we address that?
Channing, you want to go first?
Yeah, you go right ahead.
Yeah. So we'll start with the things that were just mentioned, and then add to that the issues that Channing raised about mistrust in the research enterprise. So if you look at data around mistrust in health practitioners, we actually do pretty well compared to mistrust in medical research among minority populations. So there's a terrific example of this when there was a vaccine for HIV that was developed relatively early in the epidemic, and initial results looked like it was actually ineffective for white people, but maybe effective for Black people. But there were only like 11 Black people enrolled in the entire study of several thousand people. And that's not an accident. There are reasons why minority enrollment in clinical trials have been difficult to achieve, and there are also reasons why, in a circumstance like this, people will mistrust that there is actually, well, they'll believe that there is a cure out there, and it's only available to people in the NBA or to people with a lot of wealth and access. So I think this is all sort of interlocked, and our responsibility is to try and be transparent and clear about the criteria. And this is why, by the way, I'm very proud of our state. I think, as far as I know, we're the only state that has really emphasized the need for a blinded review process, so that we can literally say the people making this decision do not know what your race is.
Thanks, Matt. I agree with everything Matt said, and I'm not sure that it's necessarily the inclusion-exclusion criteria with research,
Right.
but more these structural and historical contexts that prevent people from participating in research. And then you run into the opposite side of the problem. Like, one of my favorite examples is the Framingham Health Study, which is used for heart disease globally, and it's like 100% white. So
Yeah.
how is that really relevant to a diverse community in the way that our country looks?
Yeah.
It's really important right now with the rapidity with which clinical trials are being conducted and enrolling, and the need to pause and think about and make sure that the samples in those trials are going to be represented.
Let me come back to an initial point that was raised, and it has to do with informed consent at end of life or with other interventions. How do we approach that when we really don't understand what COVID looks like yet in our healthcare system? In other words, we really don't understand whether someone 14 days out from being intubated or on ECMO for for a week or two is someone who will survive their illness. We do know that a number of patients have done very well with ECMO in our system, and we do know that so far about 1/3 to 40% of the patients that have been intubated in our intensive care unit, who, by the way, are receiving outstanding care, have been extubated and are doing well. So the question is, how do you really inform the patient? How do you work with the physician when there are these unknowns, when there are these gray areas in terms of outcomes?
Maybe David, this is why my brother, who's the electrical engineer, tells me why he can't imagine practicing medicine, because there's so
That's right.
uncertainty in it, and I do them even if we take outside of COVID, if we took the medical decisions that we're used to counseling people about, we're still left with the sort of somewhat impossible conundrum of, I can tell you from a population, I can tell you what the data show, and this is whether it's CPR outcomes or benefits from a chemotherapy or whatever. We're working from population or study-based data down to that individual, and I think that that is where we are giving people our best informed decision or advice. I mean, even if you take out the COVID piece of it and you talk about just like the CPR decision, independent of COVID, and you look at outcomes of, in-hospital resuscitation for people, especially older and with comorbidities, and you look at the poor outcomes there, you could even start there, even if you took COVID out of it. And I think we have to remember that we live with this all the time in medicine, and we really, it's our obligation to make recommendations based on the best available data, knowing that especially when it's in a new disease like this, that data is going to be evolving. So I actually don't see it all that different, David, from the everyday advice and counseling that we give to patients based on available data.
This may be one of those areas where we can get a little better at this as a result of this event. So I should give a shout out to Peter Sutil, Tel Bennett, Dave Albers, Peter DeWitt, Seth Russell, Jake Stroh, Michael Kahn, Michelle Edelman, Sarah Davis, Lenny, I could go on. All the people who have been working on developing the scoring system, which is designed to be able to give us 95% confidence intervals around a risk of mortality if you needed to be intubated right now, or if you're already on a ventilator. What is your risk of mortality moving forward? We have an enormous amount of data available to us now that we didn't have 10, 20, 30 years ago when things like the SOFA score were being invented and tested. So I think
enormous information now that we didn't have a month ago.
That's right, about COVID, and that's correct. And none of the scoring systems take into account D-dimer. Right. None of the scoring systems take into account LDH. None of the scoring systems take into account blood type. And there are things that we now know are actually important in terms of predictive accuracy of an algorithm that we can now use that we didn't have a month ago.
Yep. Dan, you want to say something?
Yeah, if I could jump in real quick. And uncertainty in decisions is part of medicine, and it's part of what makes our jobs really interesting. But there's a lot of things we do know as well. Putting on my geriatric hat, we know, an 85-year-old who spends 2 weeks in an ICU, we know what that looks like afterwards. We know how long it takes to recover from that, and we have a lot of data of people who do that. How many get back to their prior level of functioning? Those things that we already know, that we do every day, as Jean said, we can use to inform these things, even if we don't know the exact prognosis of COVID. We know what no movement does to your sarcopenia and your muscle strength laying in an ICU bed. So there's things we can pull in from other illnesses to apply here too.
Okay. Thanks very much. I think this is a good place to end the discussion. Next week, we're going to be talking about vaccine development specifically for COVID. I look forward to the discussion. I want to thank all the speakers today and all the participants. It's been a great discussion. I've learned quite a bit. Have a good day.
Thank you.
Thank you.